Yeah, good morning, dear students. So today we are going to discuss about what is the clinical application of whatever you have studied in your anatomy, and whenever you have done the upper limb, breast as well as the upper limb, what are the important clinical implications that you have to correlate with whatever the upper limb anatomy and the breast anatomy. So first of all, we will discuss about the clinical anatomy of the breast. So there are patients comes with certain kinds of problem, but that we have to identify that properly. So this patient is a 25-year-old male. He has a skin lesion in his chest from childhood, but he didn't bother about that. But now he has some concern about that, thinking it may be a malignant, or it may be it might cause some problem later on in the future. So he has presented with that, right? Yeah, this is another case, a 60-year-old female. She is presented with the breast pain for about 3 months duration, but when you see the patient's breast, there are some appearances like this. So why it is occurs? What is the anatomical basis behind this kind of clinical conditions? So we have to discuss that. Okay. So when it comes to a clinical anatomy of the breast, there are certain things that you need to understand, you need to concentrate. There are conditions called accessory nipples, and then there are conditions called aberration of normal development and involution, right? So that is we call ND. So I will discuss that. What do you mean by ND? So that is number 2. Then the breast cancer, as well as the occurrence of breast cancer and the features, how it is correlates with the anatomy of the breast, how the changes occurs related to the anatomy. So that is the third important things we have to discuss. And then we have to know a certain important anatomical points about axillary lymph nodes. That is the important things in the breast we will discuss. So accessory nipple is one of the congenital, one of the anomaly that is seen in about 1% of the females, as well as 0.5% of the males. And you can see there's a line called milk line, right? It's a milk line. So or it is called the memory line. So the memory line, it is starting from the anterior axillary line, right, as well as it is runs below to the inguinal region. So people can have any accessory nipple or even accessory breast along this line, So whenever you see a patient with some kind of a spots here, so I can show you. So these are the two kinds of patient, the previous patient that we have discussed earlier. So they comes with the lesion along the milk line. So whenever you see any lesions like this along the milk line, that indicate it is the accessory nipple. So accessory nipple is one of the anomalies people might get, but usually it is single, but sometimes they can have multiple. So patient can have a more concern about this. So we have to know about there's an accessory nipple along the memory line. So you can have anywhere else in this line. The common places are, it is the anterior axillary line. So the first picture you can see the anterior axillary line is one of the common place, and the second one you can have a inframammary grease or below the breast. So these are the common sites of accessory nipple. Then we go with the phases of the breast changes. What are the developmental changes the breast can have? So that is also very important to know about the diseases. So there are two phases of breast changes. We can have a development phase, or we can have a involution phase. So development phase is usually it starts from the puberty. From the puberty, the breast is develops from 15 to 25 years. So that is we call early reproductive phase. Then from 25 to 40 onwards, people can develop a mature reproductive phase in the breast. So these are called developmental phase. Then after 40 to 45, the breast is started to involute, or it is regress, right. So the glandular tissues will be replaced by fat tissues. So that is what we call involution phase, right, involution phase. So this is the two types of phases people can develop, the developmental phase as well as the involution phase. Why this is important? Because there are some changes occurs during that phase, right. So when the developmental, there are some changes we call aberration of normal development. Whenever there is a involution phase, whenever you get some changes, that is we call aberration of normal involution. So normal development is there, normal involution is there, but when there are some changes occurs in the development and involution, that is we call aberration. So that is what we call aberration of normal development and involution. Okay, so that is called ND. So I wanted to introduce this term to you all now. That is called ND. Why it is important? Because when there are changes in the early reproductive period in 15 to 25 years of age, people develop fibroadenoma. So fibroadenoma is one of the breast lump, benign breast lump, that is occurs in that age period 15 to 25. Then people go into mature reproductive period. So in mature reproductive period, the changes occurs in the breast is called fibroadenosis. That is also one of the benign condition in the breast. People comes with the breast pain. So that is called fibroadenosis. When it is regresses, the breast started to regresses, we call it an involution. So changes in involution we call aberration of normal involution. Then in that kind of a period they develop breast cyst, right, breast cyst. So that is the changes people can develop whenever the breast develops. So what are the things we have to know? There are normal developmental phase of the breast, then we have a normal involution phase of the breast. So normal development of the phase, there are two kinds, early reproductive period and the mature reproductive period, and involution occurs after the 45. Whenever there are changes occurs in that development and involution, that is what we call aberration of normal development and involution. So that is the second important things we need to discuss. Next one, I told you what is the anatomical implications behind breast cancer. So everybody knows the breast cancer. Most of the breast is divided into 4 quadrants. You can see here, right? You can see here the breast, it is divided into 4 quadrants. So this is we call upper outer quadrant. It is upper outer quadrant. Then this area we call it's a upper inner quadrant, and this area is called lower outer quadrant. Lower outer quadrant. And then this area is called lower inner quadrant, and most of the glandular structures are situated in the upper outer quadrant. So that is why breast cancers are more common. Breast cancers are more common in the upper outer quadrant. So 50% of breast cancers is situated in the upper outer quadrant. So if anybody asks why breast cancers are common in upper outer quadrant, the anatomical basis behind that is the more glandular structures are in the upper outer quadrant. So that is why people develop breast cancers in that area. Then we have to know about there are some certain structures in the breast. You have studied it in the anatomy. There are important things are the suspensory ligament of Cooper. So that is the ligament that is maintaining the breast contour, right? It's maintaining the breast contour. So that is one of the important ligament to maintain the contour. Then there are lymphatics in the breast, right? Lymphatics in the breast, everybody knows that will drain to the axillary lymph node, as well as there are ductal system. So why this is important? Because when you have a breast cancer, right? Whenever whenever people develop breast cancers, the breast cancer can infiltrate the suspensory ligament of Cooper. So that is what I have mentioned. The first one, suspensory ligament of Cooper is infiltrated, then they will develop a skin retraction. So, this is what we call skin retraction. You can see here the skin is retracted in. So, that is what we call skin retraction. So, that is one of the feature in breast cancer. What is the anatomical basis behind that is it's an infiltration to the Cooper's ligament. Okay, so that is the first one. Second one, the lymphatics. I have mentioned the second important structure in the breast you have to remember is the lymphatics. So, whenever there are infiltration to the lymphatics, people develop a lymphedema in the breast. So, lymphedema in the breast, that is because of the infiltration of the breast cancer to the lymphatics. Then people will develop this kind of a feature. This is called, what is the appearance? You can see in this picture. It is looks like a orange skin appearance, or we call it a Poderange appearance. You can read in the books. It's called Poderange appearance. You will learn that later on, but I just wanted to introduce these terms, right? So, this is what occurs, the lymphedema in the skin. Easily you can remember it's like a orange skin. If you see the orange skin, the appearance will be the same. So, it's called orange skin appearance or a Poderange appearance. Third one I have mentioned about the duct. Breast, they have ductal system. So, whenever there is a breast cancer that is infiltrating to the duct, then they will develop a nipple retraction. So, the nipple retraction, that is there will be some infiltration to the ductal system. So, that is why I told you the breast cancer, the anatomy, what is the clinical features related to the anatomy behind that. Whenever there is an infiltration to the suspensory ligament of Cooper, they develop a skin retraction. Whenever the tumor infiltrates to the lymphatics, they develop a lymphedema, that is orange skin appearance, as well as people will develop a nipple retraction. So, this nipple retraction is the third one. So, this is important about the breast cancer features. Next one, if we concentrate on lymphatics of the breast, so that is the axillary lymph nodes. Everybody knows there are 5 groups, right? There are 5 groups. Number 1 is called anterior group, and 2 is called medial or middle group. Third one we call it a posterior group, and fourth one we call it a posterior group, and third one we call it the central group, as well as this the apical group. But you have studied this, but when it is comes to a clinical implication or a surgical management, we divide the lymph nodes into 3 levels, not like the levels we have discussed as this. So, it is there are drainage to anterior, middle, posterior, central, apical will be there, but for the clinical purposes we divide the lymph nodes into 3 levels. How we divide these 3 levels? According to the pectoralis minor muscle. So, pectoralis minor muscle, you can see the axillary vein, right? Axillary vein, and its crosses behind the pectoralis minor muscle. So, any lymph nodes that is below the pectoralis minor muscle is called level 1. Any lymph nodes that is behind the pectoral muscle, that is we call level 2, and any lymph nodes that is above minor muscles level, we call it a level 3. Why this is important? Because if anyone is having a breast cancer, we have to do axillary clearance. What do you mean by axillary clearance? Is we have to remove the lymph nodes in the axilla. So, whenever we remove the lymph nodes in the axilla, usually we remove level 1 and level 2, level 1 and level 2. So, that surgery, if you do a mastectomy, if a patient is having a breast cancer, we have to do a mastectomy, as well as we have to remove all the axillary lymph nodes, not all, most of the axillary lymph nodes, that is indicate axillary clearance. So, mastectomy plus axillary clearance is called modified radical mastectomy. That is also you will learn later. That is one of the surgical management we do whenever there is breast cancer. So, why I wanted to stress that here is we remove in modified radical mastectomy, we remove the level 1 and level 2 lymph nodes, and if anything palpable during surgery, then only we remove the level 3, otherwise the level 3 is not removed. So that is the important things about your drainage is important, as well as how you divide the lymph nodes into 3 levels. That is also it is important. Even in your MCQs it can be asked what is the level 1 lymph node, so that is below the pec minor muscle, and what is the level 2, that is behind the pec minor muscle, and what is level 3 is above the pec minor muscle. Okay, so that is the lymph node important. And you know, these lymphatics, it's drain the upper limb as well. So if you remove all the lymph nodes during modified radical mastectomy, people tend to develop lymphedema of the upper limb. So lymphedema of the upper limb is one of the complication after surgery, after modified radical mastectomy. You can see here this woman, she has undergone a mastectomy here, and after the mastectomy she has developed a lymphedema. So this lymph is swollen compared to the opposite limb. So that is the important things you should understand. So why people develop lymphedema of the upper limb after the modified radical mastectomy or a removal of the breast? Because we do axillary clearance, we remove all the axillary lymph nodes, so they can develop lymphedema. So that is the third important things we have to discuss, right? So you need to know. So the first one I have mentioned in the breast, accessory nipple. Why it is important? Because a lot of people, they might have a concern, and as a doctor you should know what is that. So that is accessory nipple. Then there are breast lump. Benign breast lump occurs in the breast along the development. So that is what we call ND. ND is an aberration of normal development and involution. That is the second things we have to know. And the third one, how the breast cancer occurs in a particular place, that is a upper outer quadrant of the breast, as well as the breast cancer causes some clinical features according to the anatomical, there are anatomical structures that is infiltrated, as well as we have to know about the lymphatic drainage of the breast. That is, we divide that into 3 levels, but whenever we do the lymph node dissection or whenever we remove the lymph nodes, people might develop lymphedema of the upper limb as well. Okay, so that is the important things we have to discuss. You should know the clinical anatomy behind the breast. Okay, can you all hear me? Are you all with me? Okay, yeah, good. Otherwise I don't know whether I am talking alone and you all have lost. So that's why I wanted to check. Okay. So we have finished the clinical anatomy of the breast, and now the next thing is the clinical anatomy of the upper limb, right? So what are the important clinical implications we should understand? So these are some patients. This is one of the 25-year-old person. He has fall onto a ground, right, with the outstretched hand. Outstretched hand is he fall onto the hand, and he is complaining of pain around the shoulder region, and this is how whenever we examine him, he has a small lump over the near the shoulder. So what is this? So we need to know what is this. There's another patient. He is again a 30-year-old male. He is presented, he had a fall again with an outstretched hand, and then comes with a severe right-sided shoulder pain, right-sided shoulder pain. And if you compare the left side and the right side, you can see there are some difference here, right? So that is, we have to know what is this. And there is one of the 10-year-old child. He has fall again. He had a fall, and whenever he fall, he has put the hand to support, and then he has developed a severe pain as well as the swelling in the elbow region. So he presented with this kind of features. So we have to know what is the problem behind this, right? So these are the cases we get in surgery, and there are some anatomical basis behind this as well. Okay, so we divide the upper limb clinical anatomy into section, that is shoulder, then we discuss about the arm, then we discuss about the forearm and the wrist as well as the hand. So, shoulder, when it comes to shoulder, we have to know about the clavicular fracture is one of the common condition around the shoulder people might get. So, you know, shoulder girdle is formed by clavicle as well as the scapula. So, the clavicular fracture is one of the common fractures. So, a few things you have to know, you have to touch a few things about that, as well as shoulder dislocation. Shoulder dislocation also, it is one of the main things we need to discuss. So, when it comes to clavicular fracture, usually when the clavicular fracture occurs whenever a person fall on outstretched hand. So, this is the patient we have seen earlier. So, he fall on outstretched hand and then he comes with the lump. So, clavicle, you know, clavicle is divided into three parts, the middle 1/3, right, sorry, medial 1/3, then the middle 1/3 as well as lateral 1/3, and most of the fractures occurs in the middle 1/3. So, middle 1/3 of the bone is the commonly the fracture occurs, and why they develop this kind of a lump kind of things in the near the shoulder. So, the anatomical basis behind that is the sternocleidomastoid muscle is attached to the clavicle. Sternocleidomastoid muscle is attached to the clavicle, and that is supports the upper limb as well, right. So, the clavicle supports the upper limb as well. Whenever there is a fracture, what will happen? The proximal segment will be pulled up by sternocleidomastoid muscle, and the distal segment, fractured segment will be low down because of the weight of the upper limb. So, because of that, people develop this kind of a lump whenever there is a clavicular fracture. So, you can see in this X-ray. So, in the X-ray you can see whenever there is a fracture here, right, it is in the middle 1/3, the fracture occurs in the middle 1/3, and you have a proximal segment. This is a proximal segment, and you have a distal segment. So, the proximal segment is attached to the sternocleidomastoid muscle. So, it will pull up, the proximal segment will be pulled up, and the distal segment will drop up because of the weight of the upper limb. So, that is how people develop this kind of a features, the lump. So, whenever clavicular fracture, people comes with the lump in that region, the anatomical basis behind that is the proximal segment is pulled up by sternocleidomastoid muscle. So, that is important to know about the clavicular fractures. Next one, shoulder dislocation. So, I told you the shoulder, it can get dislocated, and it is common compared to the hip dislocation. So, if you know the hip dislocation, you know you have acetabulum, and the acetabulum is very deep, and because of that usually the hip dislocation won't occur. But when you come to the shoulder, because of the increased mobility, shoulder it has a very much increased mobility, and because of that the glenoid fossa is very shallow. The glenoid fossa is shallow, and the integrity as well as the strength of the shoulder is maintained by the ligaments and the muscles around that. That is what we call rotator cuff, right, rotator cuff. So, because of that the glenoid fossa is very shallow, there is a possibility they can have a shoulder dislocation. So, that is the anatomical basis behind the shoulder dislocation. So, there are two types of shoulder dislocation. You can have an anterior shoulder dislocation, that is the commonest type. 95% of the time the shoulder dislocation occurs anteriorly. So, that is the anterior shoulder dislocation. So, sometimes you can have a posterior shoulder dislocation, that is very rare, it is only about 5% you can have a posterior shoulder dislocation. So, the common shoulder dislocation is an anterior shoulder dislocation, and whenever people get anterior shoulder dislocation, the deltoid contour will be flattened, right. Why? Because in this area you can see the prominent acromion process will be there. Because of the prominent acromion process, the shoulder contour, deltoid contour is lost. That is the typical feature whenever someone comes with the shoulder dislocation, right. So, compared to the opposite side, the left side, you can see the contour is lost here. So, that indicates an anterior shoulder dislocation. And you know, the axillary nerve is wind around the surgical neck of the humerus. So, everybody knows humerus, it has an anatomical neck as well as the surgical neck, and the axillary nerve goes around the surgical neck. So, whenever there is a dislocation, the axillary nerve also will be affected. Okay. So, whenever the axillary nerve is affected, they will have a sensory loss over the batch area. This is what we call batch area. Batch area is the lower part of the deltoid region. So, that batch area people will develop sensory impairment or sensory loss. So, that is the feature of axillary nerve injury. So, anterior shoulder dislocations can cause axillary nerve injury. So, if you see this kind of patients, always you have to check whether the sensation is preserved or it is lost in this batch area. So, that indicate axillary nerve injury. And if you see in the X-ray, the head will be in the subcoracoid position. So, this is called coracoid process, right. It is an acromion process. You have a coracoid process and the head will be just below that. That is the identification of anterior shoulder dislocation. Usually, you do not get a head below the coracoid process in a normal position, but whenever you get an anterior shoulder dislocation, it will come just below the coracoid process. So, that is what we call subcoracoid position. So, whenever you see an X-ray, how to tell it is a anterior shoulder dislocation? You have to tell the head of the humerus is in the subcoracoid position. Next one is the posterior shoulder dislocation is very rare, right. It is usually commonly it is missed, and usually it is caused by some forced internal rotation, right, of the abducted arm, or sometimes with the direct blow also people might develop a posterior shoulder dislocation. It is common after some conditions, for example, epilepsy, electroconvulsive therapy and electrocution. You can easily remember all E, 3 E's, 3E. So, epilepsy, electroconvulsive therapy is given in psychiatric condition, right. So, that is you will learn later on, as well as electrocution. So, whenever somebody had electrocution or somebody had epilepsy and presented with shoulder pain, we have to think about posterior shoulder dislocation, right. And you can see in the X-ray, it is when the posterior shoulder dislocation occurs. Here you can see the head. Here in this first X-ray, you can see the head that is in the medial position. That is the usually in the glenoid fossa, it will be in the medial position. But when it goes back in posterior shoulder dislocation, it looks like a bulb. So, this is called bulb. This is called bulb sign. So, bulb sign is one of the feature in the X-ray that will indicate it is a shoulder dislocation. So, these are the two important things you have to know: the clinical anatomy of the shoulder, the clavicular fracture, as well as shoulder dislocation. Next region is the arm. What are the important things we need to discuss in the arm is there are condition called rupture of long head of biceps, right. So, I do not know whether you heard this earlier. So, biceps, it has a long head and a short head, right, everybody knows. So, long head, whenever there is some rupture, so that is called what, rupture of the long head of biceps. And we have to know about the fracture surgical neck of the humerus and what is the clinical implication behind that, and fracture shaft of the humerus and why it is important to know about the fracture shaft of the humerus. And there are condition called supracondylar fracture. Supracondylar fracture, you know, the humerus, you have two epicondyle, the medial and lateral epicondyle, and any fractures occurs just above the epicondyles, that is what we call supracondylar fracture. And medial epicondyle injury, why medial epicondyle injury is important in surgical practice, that is also we need to know, as well as there is a condition called epicondylitis. So, what is epicondylitis? We need to discuss that. So this is what we call rupture of the long head of biceps. It is usually whenever there are some degenerative diseases occurs around the shoulder joint, that will cause us the weakening of the long head of the biceps, and sometimes it will rupture. So it is usually common in manual workers. So whenever they do manual works and all with the degenerative disease around the shoulder joint, and it will weaken the long head of the biceps, and it can result in rupture. Usually they comes without any pain, without any feature. They all of a sudden they will see there's a lump. So whenever they extend, they won't see any lump because the biceps is not contracting. But whenever they flex the arm, then they will see there's an obvious spherical lump in this region compared to the opposite side. So compared to the opposite side, this spherical lump with the groove in the anterior, the proximal part, so that is indicate it's a rupture of the long head of biceps. So this is one of the clinical anatomy you have to know. Because of the rupture of the long head of biceps, people can present with some kind of a sudden onset of lump appears whenever they flex the arm. So this is one of the conditions we need to know. Second one is the fracture surgical neck of humerus. So everybody know the neck of the humerus. There are two type of neck of the humerus. You have a anatomical neck and you have a surgical neck. Why we call it an anatomical neck? Because that is the true neck. But most of the fractures occurs lower down, so that is what we call it's a surgical neck, right? Surgical neck. So you can see the surgical neck. Early also I have mentioned in shoulder dislocation, anterior shoulder dislocation, there's one nerve can be injured, is the axillary nerve. So you can see the axillary nerve that is wind around the surgical neck. So whenever people get fractures in the surgical neck, they can develop axillary nerve injury as well. So they can present with their sensory loss over the batch area or a deltoid region. So that is the feature of fracture surgical neck of the humerus. And next come to the shaft, fracture shaft of the humerus. What is the importance about the fracture shaft of the humerus is, you know there's a radial groove behind the humerus, right? Posterior part of the humerus you have a radial groove, and the radial nerve is traveling through that radial groove. So whenever there's a whenever there's a fracture shaft of the humerus, this radial nerve can be damaged or it will be injured. So that will cause us radial nerve palsy. So that is the importance behind the shaft of humerus fracture. So whenever they develop a whenever they develop a radial nerve injury, they develop a wrist drop. So this is what we call wrist drop. So wrist drop, they can't extend the wrist because of the radial nerve injury. So the wrist will be in a flexed position. So that is what we call wrist drop. So that is the feature people might develop after the radial nerve injury. So whenever you see any patients in the future with the shaft of humerus fracture, always check the radial nerve. Always check the radial nerve whether it is intact or not. So how to check the radial nerve whether it is intact or not? You can just ask the patient to extend. If they can't extend, if it is in the flexed position, that indicate it is a patient is having radial nerve injury. So that is the second important things we need to discuss about the fractures in the humerus. And the next important fracture is the supracondylar fracture of the humerus, right? So already I have told you the people will have the humerus, it has a medial and lateral epicondyle. So any fractures occurs above that, it's called supracondylar fracture. This is the fracture commonly occurs in children. So because of that we call it a childhood fracture. It's a childhood fracture. So whenever they fall on outstretched hand, that is whenever they fall on the hand, whenever they land on the hand, that is what we call fall on outstretched hand. These supracondylar fractures are very common. So whenever there is supracondylar fracture, they will present with swelling, right, of the elbow region. So whenever you see a swelling around the elbow region with some tenderness, then you have to think about supracondylar fracture, especially in children. Common age is 5 to 15 years. 5 to 15 years, this is one of the important things that you have to identify. Okay. What's the problem with supracondylar fracture? Because that can causes brachial artery injury. So because brachial artery is very close to that region, so because of that they can develop a brachial artery injury. So you can see the brachial artery is traveling just anterior to the supracondylar region. So whenever there is a fracture, the brachial artery can be damaged, right? It can be damaged, or even it can cause us kinking. Kinking also, that will cause us loss of pulse distally. So that can cause kinking, or even it can damage the brachial artery. So if it is brachial artery is injured or damaged, what will happen? The blood supply to the forearm will be affected. So kinking is causing loss of pulse, then we have to manipulate the fractures, and then we have to reduce it. Okay. So that is the important things about this. But why I wanted to stress about this brachial artery, because there is a condition they can develop Volkmann ischemic contracture. That is what I told you, complications mainly in a supracondylar fractures, they can develop a brachial artery injury. Because of that, they can develop a Volkmann ischemic contracture. So what is Volkmann ischemic contracture? This is because of the poor blood supply to the forearm muscle. Whenever the blood supply to the forearm muscle is very poor, what will happen? The flexor compartment muscles will be affected. So whenever the flexor compartment muscles are affected, people comes with this claw-like deformity because of the flexor compartment muscles are replaced by fibrous tissue. So flexor muscle compartment is replaced by fibrous tissue. They can develop a flexion contracture of the hand and the wrist, and they comes with the claw-like deformity. So this is, again, I wanted to introduce this condition to you all. It's called Volkmann's ischemic contracture. Ischemic is, the limb is ischemic because of the poor blood supply, and because of that the muscles will die and it will replaced by the fibrous tissue. So that will cause us contracture. So that is called Volkmann ischemic contracture. So that is the one of the complication of supracondylar fracture. So we have discussed about surgical neck of humerus fracture. We discussed about the mid shaft of the humerus fracture, and the nerve that is affected in that is the radial nerve, as well as we have discussed about the supracondylar fracture and what are the complications people can get because of the supracondylar fracture. It is the Volkmann ischemic contracture because of the injury to the brachial artery. Okay. So next one is the median epicondylar injury. Median epicondyle. Whenever there is an injury to the median epicondyle, that is also one of the clinical significance behind that, because the ulnar nerve is more superficial, right? Ulnar nerve is more superficial or subcutaneous. It is just subcutaneous in the medial epicondyle. So whenever there is a slight injury in the medial epicondyle, that will compromise or that will injure the ulnar nerve. So in the elbow, ulnar nerve is more vulnerable for injury. It's more chance of damage because the ulnar nerve is very superficial in that region, and it is goes behind the medial epicondyle. So anybody comes with the medial epicondylar injury, you always check the ulnar nerve is intact or not. So ulnar nerve always need to be checked. So that is median epicondylar injury. Then epicondylitis. There is a condition called epicondylitis. What are the muscles arising from median epicondyle? Sorry?
Flexor muscles of forearm.
Yeah, good. So flexor muscles of the forearm is arising from the medial epicondyle. That is a common flexor origin, as well as extensor muscles are coming from lateral epicondyle. So whenever they have a repeated functions of the hand, right, sometimes they can have some inflammation around the medial epicondyle, or sometimes they can have a inflammation around the lateral epicondyle. So that is the inflammation around the medial epicondyle, we call it a medial epicondylitis. And whenever there is a inflammation in the lateral epicondylitis, you know, it is called lateral epicondylitis. So whenever somebody comes with the elbow pain, how to differentiate whether it's a medial epicondylitis or a lateral epicondylitis? So you have to know there are two important things, a tennis elbow as well as the golfer's elbow, right? So what do you mean by golfer's elbow? Medial epicondylitis, whenever there is an inflammation in the medial epicondyle, that is what we call golfer's elbow, right? It's called golfer's elbow. And lateral epicondylitis, we call it a tennis elbow, right? So how to check whether it's a golfer's elbow or a median epicondylitis? You ask the patient to flex against resistance, because everybody knows medial epicondyle is the common flexor origin. So whenever you flex the hand against resistance, people develop pain over the medial epicondyle. So that is indicate golfer's elbow. And when they do the extension, everybody knows the common extensor origin is the lateral epicondyle. So they will get a pain whenever they do the extension of the wrist in tennis elbow. So that is the golfer's elbow and tennis elbow. You can easily remember, sometimes you might mix up the names, right? So but you can easily remember, always think about medial to lateral, and if you think about the alphabetical order, golfers come first, so that is medial, and then you get a tennis elbow, right? So that is a golfer's as well as the tennis elbow. So this is what we call epicondylitis, medial and lateral epicondylitis. Then we move to the forearm, right? We go to the forearm. So forearm, what are the most important things that we need to know is radius and ulnar fractures, as well as there's a distal radial fracture. What are the important things behind distal radial fracture? Okay, so that is the important things we have to know. So you know, the radius and ulna are together. Whenever there's a fractures, usually the fractures occurs together. So everybody knows, because it's a paired bone. So whenever there's a fractures, it very rarely you get a single bone fracture. So usually the both bones will be fractured, right? Both bones will be fractured. So that is the usual form. But if you have a single bone fracture, right? If you have a single bone fracture, then there will be a dislocation of radio-ulnar joint as well. Otherwise, you can't have a single fracture, right? You can't have a single fracture. So that is the important things about the forearm bone fractures, right? So in the upper part of the film, you can see there's a single fracture in the proximal, a single fracture. Then you will see there's a dislocation in the proximal radio-ulnar joint. Otherwise, you can't have a single fracture unless it's a direct blow to that bone. Otherwise, you don't get a single fracture whenever somebody fall or not. So that is the clinical implication behind this anatomy, because this bone are paired bone, you can't have a single fracture. If you have a single fracture, always you have to check whether there's any dislocation in the proximal radio-ulnar joint. And this one distally, right? Distally you have a fracture. Proximally you can get a fracture in the ulna. So whenever there's a proximally you get fractures in the ulna, you get a proximal radio-ulnar joint dislocation. And distally you get a fractures in the radius, then you get a distal radio-ulnar joint dislocation. So without the distal, without the joint dislocation, the single fractures are rare. So what is the clinical anatomy you have to understand in forearm fractures is, the forearm bones are paired bone. So usually whenever you get a fractures, the fractures occurs together in both bones. But whenever there's a fracture occurs in a single bone, always you have to check about whether there's any proximal radio-ulnar joint dislocation with the proximal fracture and the distal radio-ulnar dislocation with the distal fracture. So that is what we have to understand in this. So that is the radio and ulnar fractures. So remember, one is called Monteggia fracture, and the other one is called Galeazzi fracture. So you can just refer the books, Monteggia fracture and the Galeazzi fractures. So Monteggia fracture is proximal ulnar joint ulnar joint fracture as well as proximal radio-ulnar dislocation is called Monteggia fracture. This one, distal, you get a distal distal radial fracture, and then you can get a distal radio-ulnar dislocation. So that is what we call Galeazzi fracture. So you can remember where the fractures occurs. Proximally, the joint is formed by ulna. The radius is just adjacent, but proximally the joint is formed by ulna. So whenever there is a fracture occurs in the proximal bone, it should be a fracture in the ulna. You can't get a fracture in the radius in proximally. You can get with a direct blow and all, but usually you have to get a fractures whenever somebody falls. The proximally you can get a fractures in the ulna because that is the bone forming the proximal elbow joint. When it comes to distal, whatever the pressure or whatever the forces are transmitted from ulna to radius. So when it is forces are transmitted from ulna to radius, what will happen? The distally the joint is formed by radius mainly. It is not the ulna. Ulna it is adjacent, but the radius is mostly forming the fracture. So if anybody asks proximally which bone can fracture, it is ulnar fracture. Distally what bone can get fracture? It is a radial fracture. So proximal ulnar fracture is associated with proximal radio-ulnar dislocation, that is called Monteggia fracture, and distally the radial will be fractured and there will be a distal radio-ulnar dislocation, that is what we call Galeazzi fracture, Monteggia and Galeazzi. So you can easily remember, always remember G for gravity. G for gravity. If you think about G as a gravity, that is in the lower part, right? Lower part. So lower fracture is called Galeazzi, that is a lower part here, and the proximal one is Monteggia. So that is the fractures we need to understand in the radio-ulnar fractures. Then we come to the distal radial fracture. So distally the radius is forming the wrist joint. So distally the radius is forming the joint, the wrist joint, and you can have a fractures in that area. So that is what we call distal radial fractures. There are two types of distal radial fracture. We can divide the distal radius fracture into two. There are some fractures occurs outside the capsule. So that is what we call extracapsular fractures, right? Extracapsular fractures. And there can be a fractures occurs inside the capsule. When the fracture occurs inside the capsule, the articular surface also involved. Articular surface also involved. So extracapsular fractures, there are two types. You would have heard that Colles fracture and Smith fracture. Colles fracture and Smith fracture, that is called extracapsular fracture. So Colles and Smith, the articular surfaces are not involved, and it is not occurs inside the capsule, it is occurs outside the capsule. But when the articular surfaces are involved and it is within the capsule, that is we call Barton's fracture. So hereafter understand there are three types of fractures. You should know about the distal radius. You can divide that into two types: extracapsular fractures, that is Colles and Smith fracture, and intracapsular fracture is a Barton fracture. The common one is the Colles, right? Colles. So Colles is whenever they fall on outward hand, or that is what we call outstretched hand, whenever they fall like this, then they develop Colles fracture. And if they fall on inward hand, so they fall on like this, then they will develop a Smith fracture. So Colles and Smiths are similar, but it is displacement, according to the displacement only it is divided, it is named as Colles and Smith fracture. So Colles fracture occurs when the person is fall on outstretched hand, and Smith fracture occurs when they fall on inward hand. So that is the difference between Colles and Smith fracture. So Colles fracture, it is one of the transverse fracture in the distal radius, that usually about 2 centimeter from the wrist joint. So that is why we call it an extracapsular, right? Extracapsular. It is common in elderly people, mostly in females. So females, whenever they are osteoporotic, right? They are osteoporotic, then it is very commonly they develop Colles fracture, even with a slight fall. Even with the fall on outstretched hand, even with a slight fall, they can develop a Colles fracture. So remember that Colles fracture is one of the common type of distal radial fracture, more commonly occurs in female because of the osteoporosis, as well as more common in elderly. Commonly it is occurs due to fallen outstretched hand, and it is one of the extracapsular or extra-articular fracture. How is the deformity? Whenever you see a Colles fracture, we call that deformity is a dinner fork deformity. Dinner fork deformity. So you can see here the Colles fracture, distal radial fracture, the distal fractured segment, distal fractured segment, sorry, this one, distal fractured segment displaced dorsally. It is displaced dorsally. So this one, distal fractured segment displaced dorsally. So they will get a appearance as a dinner fork. So this is what we call dinner fork abnormality whenever somebody comes to the Colles fracture. Somebody tell me, in Smith fracture, what will happen to the distal segment? Anyone can tell me?
The distal segment will driven anteriorly towards palmar surface.
No, you have to tell ventrally or dorsally.
Ventrally.
Yeah, okay.
It will move ventrally.
Yeah, good. So that is how, this is what the Smith fracture appears. So first one is the dinner fork deformity. The distal segment moves dorsally. So that is why they develop a dinner fork deformity. This is because of the fallen outstretched hand. And when it is they fall on inward hand, the distal segment will move ventrally. So when it is moves ventrally, that is what we call Smith fracture. So that is the difference between Colles fracture and the Smith fracture. Colles fracture, the distal segment moves dorsally. Smith fracture, the distal segment moves ventrally. So that is why in Colles fracture you get a dinner fork deformity, and Smith fracture is opposite to that. So that is the two types of fracture. It occurs in the distal radius. So these two fractures, these fractures you can see, there is a fracture here in the distal radius, but it is not involved in the articular surface. So this is the articular surface, there is no involvement in that. But when it comes to Barton fracture, you can see the fracture is involved in the articular surface as well. Here you can see the fracture involved in the articular surface. So when the fracture is involved in the articular surface, that is called Barton fracture. So that is the difference between Colles, Smith and the Barton fracture. So hereafter you should know distal radial fractures, there are three types. There are two, we can divide that into two groups. Extra-articular fractures is Colles fracture and the Smith fracture, and intra-articular fractures, it is a Barton's fracture. And when the distal radial segment moves dorsally, that is what we call Colles fracture, that is occurs in fallen outstretched hand. And when the distal segment moves ventrally, that is we call Smith fracture, that is what it is occurs in when they fall on inward hand, right. So that is the difference between these two. Okay. Next region we will move to the wrist as well as the hand, right, wrist and the hand. There are two important things we need to discuss about carpal tunnel syndrome and the scaphoid fracture. What is the important anatomical basis behind these clinical symptoms as well as the clinical features. So first of all, in the wrist, you know there is a tunnel called carpal tunnel. So you know there is a flexor retinaculum. Flexor retinaculum is forming the wrist into a tunnel, and through this tunnel the median nerve travels, right. There is a median nerve, so you can see there is a median nerve here. So that is within the carpal tunnel, and this space is very, very dense. There is no space other than this, whatever the structures in this, right, is very, very dense area. So even if you have a slight inflammation, so even just a slight swelling or edema in this region, that will compromise or compress the median nerve. That will compress the median nerve. So that is what we call carpal tunnel syndrome. So what is carpal tunnel syndrome? The other name for carpal tunnel syndrome is median nerve entrapment syndrome. So median nerve will be entrapped whenever somebody develops carpal tunnel syndrome. That is the important conditions here. These people will present with numbness, right. There will be a numbness of the upper limb, numbness of the hand as well as the numbness occurs over the median nerve distribution. Whatever the places the median nerve distributes, they will develop some numbness along that. And the median nerve is the nerve mainly supplies the thenar muscles. So when the median nerve is trapped within this tunnel, they will develop a thenar muscle wasting. So thenar muscle wasting also is one of the clinical feature because of the median nerve entrapment syndrome. So it is again, it's more common in female, and common age is 40 to 50, that is in perimenopausal age. Perimenopausal age is the common age to develop carpal tunnel syndrome. It can occur in pregnancy. So whenever somebody is having a long-term steroid, diabetes mellitus, hypothyroidism, obesity, all that can cause us carpal tunnel syndrome. You will learn this one later, but if you just identify a clinical condition that can cause us numbness as well as the wasting of thenar eminence, that is the disease behind that is carpal tunnel syndrome. Next condition we have to discuss about the scaphoid fracture, right? Scaphoid bone. So scaphoid bone, you know, it is also again fractures whenever somebody fall on outstretched hand. And what is the anatomical basis or importance in scaphoid fracture is, everybody know the scaphoid, it has a waist, right? You have the scaphoid bone, it has a waist. So usually the fractures occurs through the waist, and the most important anatomical point is the scaphoid bone is the blood supply is coming from distal to proximal. The blood supply is coming from distal to proximal. So whenever you get a fracture in the waist, it's one of the common question, one of the common MCQ question, which part of the scaphoid bone go into necrosis? So the answer is, it's a proximal part. Proximal part of the scaphoid will go into avascular necrosis, or it's a necrosis. Usually we think whenever blood supply is there, the bones and everything is supplied from proximal to distal. So whenever there's a fracture occurs or whenever there's a problem occurs, usually the proximal part is spared and the distal part will suffer. But in scaphoid, the other way around, because of the pattern of blood supply. So the scaphoid bones are supplied by the artery from distal to proximal. So whenever there's a fracture occurs, the proximal segment will goes into avascular necrosis. Okay. What is the clinical features? Everybody knows, whenever you want to feel a scaphoid bone, this is what we call anatomical snuff box. Anatomical snuff box. So that is the place you get a swelling as well as tenderness. So there will be a swelling and tenderness over the anatomical snuff box that will indicate it is a scaphoid fracture. So anatomical portion of the scaphoid bone also is very important to identify scaphoid fracture clinically. So that is the important anatomical landmark you should know. So scaphoid fractures you can identify with swelling and tenderness over the anatomical snuff box. There's another conditions you should know, it is called Dupuytren's contracture, right? Dupuytren's contracture. This you should know about the palmar aponeurosis. Usually the palmar aponeurosis is there in the palm, right? So everybody knows that is one of the important fibrous structure in the palm, right? So sometimes there can be a localized thickening of the palmar aponeurosis that will cause us, there's a thread like these structures, and sometimes it is formed as a nodule. So this condition is called Dupuytren's contracture. So anybody asks what is Dupuytren's contracture, you should know there's a localized thickening of the palmar aponeurosis. So that will cause us later on a nodule as well as the strand like this, right? Strand like this. And it will affect the metacarpophalangeal joint as well as the proximal interphalangeal joint. So Dupuytren contracture, it is a localized thickening of the palmar aponeurosis, and it is later formed into a nodule, right? And it is usually the changes or the difficulty of flexion occurs. The joints are involved is the metacarpophalangeal joint as well as the proximal interphalangeal joint, and distal interphalangeal joints are not involved. Why? What is the anatomical basis behind that is the palmar aponeurosis not attached to the distal interphalangeal joint. So, distal interphalangeal joints are not involved whenever there is a Dupuytren's contracture. It is very common in males, and it is due to some repeated minor trauma, cirrhosis, alcoholism, or even in diabetes, right. These are the people, they can develop Dupuytren's contracture. So, just remember, just understand there is a concept called Dupuytren's contracture, and what is, if anyone asks what is Dupuytren's contracture, just tell it is thickening of the palm aponeurosis, and palm aponeurosis not involve the distal phalangeal interphalangeal joint. So, that joint is not involved, but the other proximal interphalangeal as well as the metacarpophalangeal joints are involved. Okay. Okay, so I will give you some homework. So today itself, read about brachial plexus injury as well as peripheral nerve injury. So brachial plexus injury also, it is a part of a upper limb, you have to know that. So that is also you have to read, as well as peripheral nerve injury. When it comes to peripheral nerve injury, there are three nerves you have to know: the radial nerve, median nerve, ulnar nerve. So, if it is a radial nerve is injured in the axilla or elbow or wrist, what are the features people will develop? When the median nerve is affected in the axilla, wrist as well as the elbow level, what are the features people will get, as well as the radius, ulnar as well as the median nerve. Okay. Okay, thank you.